So, greetings everyone, and welcome to this webinar about the practice of outpatient treatment for COVID-19. I'm here with Dr. Shankara Chetty from South Africa, with Dr. Ira Bernstein from Canada, and with Dr. Peter McCullough from the US. We have this amazingly distinguished panel of experts with us, and we are going to investigate the practice of outpatient treatment based on the best science available. So welcome, gentlemen.
Good afternoon.
Thank you. Thank you.
The way we are going to proceed will be with first kind of a dialogue I will have with Dr. Chetty. We'll do a walk-in and a walk through his practice for outpatient treatment in South Africa. We'll have a conversation about the experience, the practical experience of Dr. Bernstein with outpatient treatment in Canada. And then we'll have a discussion, all of us, about the best practices, the best therapies, all the issues of the day also relating to the variants and these various aspects of the disease. This conversation will be about outpatient treatment. It will not be about hospital treatment. It will not be about vaccines. We are going to be focused, and we want to be as helpful as possible so medical doctors from all over the world can learn from you guys, if I may be as casual as I just was. So in terms of the questions, you can write your question in the comments section. Please be brief. Put your name and also the country you are from, and be really brief because we can put them on screen then when we have the Q&A. So that will come in the second part, but you can already put your questions throughout the presentations, okay? So on this, I'm going to just remain for a talk with Dr. Chetty, and we'll talk later, Dr. McCullough and Dr. Bernstein. So, Dr. Chetty, what a pleasure to be with you today. And I think to concretely present an outpatient treatment setting, I'd like to show some pictures, if you don't mind, the pictures you provided me, okay? So let's start with... So let's start with this one. Oh, okay, sorry, I'm just confused here. Okay, this is a picture of an hospital setting. It is exactly what you want to avoid. So this image, you don't want to see it. Normally, patients should not reach a stage of the disease with that kind of treatment. So let's go to the real thing. And here is the practice of Dr. Chetty. And let me show them quickly, and then we'll be able to discuss. This is a close-up and a further close-up. So this is the practice that has welcomed several thousand patients. And this is what Dr. Chetty, tell us how you came up with this setting and what you do with patients when they present.
All right, Jean-Pierre. Thank you for inviting me to this forum. From the onset of COVID, I have a history in natural biology and a passion for that kind of thing. And from the onset of the COVID pandemic, I've had it in my head that we've been missing something. So before Corona came to my country, I had an inclination that there was some part of the pathophysiology that we weren't understanding correctly, which was leading patients to hospitalizations. And I felt that that's what we needed to be doing. So my focus in all this was to understand the pathogenesis of coronavirus. So I set up a tent outside in the parking lot of my practice, solely to keep people safe and triage and keep the positives away from the suspects and so on. And of course, good ventilation and sunlight will keep the virus away from me. And I endeavored to see every single positive patient from the first day so that I could understand the evolution of this disease before the patient got to hospital, and with particular interest on the dyspnea that was sudden in onset and leading patients to hospitalizations. Uh, I moved out of my home and such to keep my family and society safe and the rest. Very early on in the illness, I realized that the dyspnea that set in seemed to have a specific time in the disease that it started. And it was very quick in onset, in some patients rapidly progressive. There was a difference in speed, in severity, but it always seemed to present on the 8th day. So I started looking at that. I initially realized that we are dealing with, before Corona came, I knew we were dealing with an immune condition in some way. And prednisone had shown some benefit worldwide. So on the 8th day, I started patients on methylprednisolone. And I saw over 2 or 3 days good improvement in those patients. Some patients recovered by the 7th day and had none of the symptoms that occurred from the 8th day onwards. So looking at that, I was of the opinion from very early on that we were dealing with a kind of hypersensitivity reaction. Because of the variation in speed of onset and progression, there was too varied a presentation for this to be accomplished by a single virus. So I looked at the pathogenesis and I thought, well, it's likely a body's reaction to this that would create that kind of diversity. So quite early on, I started steroids and patients improved. And that drew me closer to this being hypersensitivity. Then I attempted antihistamines on that day. I tried a patient that was critically ill on a stat dose of promethazine, and I monitored her closely. And within 24 hours, a saturation of almost 70% had returned to 95. There was within a day, a remarkable improvement. I did only give a medication for a day to ensure that the antihistamine was actually making the difference. And promptly after a day, she started to deteriorate again with saturation drop as the medication wore off. I reinstituted it and she was back on the road to recovery. So this gave me a path to understanding that we're dealing with a hypersensitivity reaction. A lot of patients presented with gastrointestinal symptoms, which initially looked like a viral gastroenteritis that we see regularly. But again, with these patients, there was that deterioration with lung symptoms on the 8th day. And very quickly, it became evident that the 8th day was very important in the start of the second part of this illness. Now, remarkably, the majority of patients that I saw, excluding those with bacterial infections, co-infections, a majority of patients reported symptomatic improvement and recovery by the 6th or 7th day. There were those patients who recovered within a day or two. There were others that took a few days to get over this, but a majority of patients reported recovery feeling better by the 6th or 7th day. Now, irrespective of that improvement, there were those patients who developed dyspnea on the 8th day. And it was the dyspnea that developed had no bearing on the severity of the initial 7 days. I had patients who had infection on the first day, a sore throat. It resolved on the second. They spent the rest of the week perfectly fine engaging in strenuous activities. And then on the 8th day, started to notice in the morning the onset of dyspnea. And by the afternoon, were completely breathless and showing drops in their saturations. So I started to treat this as a hypersensitivity reaction. And I had an understanding of what I needed to be dealing with. So I found that the antihistamines, particularly histamine 1 and histamine 2 blockers for the upper respiratory or respiratory tract and gastrointestinal tract respectively, showed great benefit, immediate. This drew my attention to this being probably a type 1 kind of hypersensitivity because of the speed at which it was showing up in some patients. I've been treating it as such, Jean-Pierre. In the second wave, we had a lot more patients presenting with gastrointestinal symptoms. And those that had this reaction on the 8th day presented with far more severe reactions. That required a change in the way I handled those patients. But the main focus of my work was to understand how this disease progressed and where to intervene with different treatments. So my work basically has shown that we're dealing with a biphasic kind of illness, a viral illness in the first 7 days, and on the 8th day, some sort of trigger of hypersensitivity that leads to a release of mediators, histamine being one of them. I was always cautious about platelet activating factor and leukotrienes. So my protocols quickly included Ecotrin, aspirin, and Montelukast to take care of the leukotrienes. I found benefit with those. So I started looking at the 8th day, because with hypersensitivity, the most important thing is to start treatment early. The longer you leave it, the cascade of mediators will result in other sequelae and eventually culminate in a cytokine storm. But like with hypersensitivity reactions, if caught early, they are easy to curtail. So my entire focus became the 8th day. So when patients came into my practice, I would interrogate them about the onset of symptoms, the exact day that they started to feel unwell. I would then advise them about what might transpire exactly a week later, which is the 8th day, and what symptoms to start looking for. It so transpired in the second wave that I noticed that there was a collection of symptoms that seemed to herald the onset of this hypersensitivity reaction, not necessarily dyspnea. On the 8th day, it's body aches and pains, and the body aches and pains seem to be very typical, sort of an allergic reaction kind of pain that you'd see in rheumatoid arthritis, a burning joint pain. Fatigue to the point patients wanted to sleep, or the onset of dyspnea. So I educated patients about those three symptoms. I explained to them that they should not discount those symptoms, even if it was a solitary symptom and mild, on that 8th day. And any change from the 7th day to the 8th day should be reported timely. So this is what happened with patients. I think they understood the gravity of what I was saying, and they reported back on the 8th day. That allowed me to run certain testing to see whether I'm dealing with a complete switch on that day. The common blood test that I ran was CRPs and interleukin-6 levels, and I found a drastic change from the 6th day to the 9th day. And it showed something was happening around that time that was causing a spike in these inflammatory markers. My initial treatment, like we would treat any hypersensitivity, a bee sting for say, would be the appropriate dose of steroids to immediately reverse this reaction, and of course the relevant medication to mop up all the chemical mediators that might have been released with this reaction starting up. With that kind of treatment, I had very good clinical recovery of my patients, and in a very quick space of time. I did have those that presented too late, that required longer treatment to get the reaction under control. But all my patients showed quick recovery. The majority of my patients, 99.9% of them, had recovered completely within 14 days of the start of this reaction. In all, I've seen close to 4,000 patients right now, excluding those that I've treated over the telephone. None of my patients have had any long COVID symptoms. None of my patients have been hospitalized so far. All were treated at home and managed at home. And till this day, I have no oxygen in my practice. I've never found the need for it. Patients recovered relatively quickly, even those with very low saturations of 60, 50% some. By the next day, we'd seen an increase in those saturations. The dyspnea slowly subsided, and within a day or two, they were comfortable on room air. This progressed over time, and people in the area became very well aware of the importance of that 8th day. Fortunately, I had a few pastors in the area fall ill with COVID. The education of the 8th day rang true with them as well. They had the reaction. It was in some quite severe. I caught it early. I managed to manage it through, and they recovered. So they took it upon themselves to talk about this to their congregations. So very quickly in my area, the message about the 8th day spread and the importance of early presentation so that we could get you through the initial viral illness without it complicating what might transpire on that 8th day. That has been the crux of my treatment, Jean-Pierre. It has been more towards the pathogenesis of COVID and where we should be intervening in the disease process and where we should be changing our approach. It has proven to be a biphasic illness. I've been in talks with Dr. Marcus Sanchez-Gonzalez of Larkin Research. He's done a paper that's shown that there's a lot of pathology that reflects hypersensitivity. From the start, I was of the opinion that the clouding in the lungs that we were seeing in the ground glass appearance reported on X-rays was actually a hypersensitivity like pneumonitis rather than a viral pneumonia. I was of that opinion for two simple reasons. There was good clinical recovery on day 6 and 7, which I thought would be the end of the viral phase of this illness. And of course, the PCR test is not a reliable test for determining live virus. It tests just a fragment of this virus. So I started looking at viral culture studies around the world. And what I found was that it was pretty difficult to culture this virus from swabs taken after the 7th day. And so I looked at that and I thought, well, if we got a virus that's living for 7 days and we're having this progression, we're probably having a change in the pathologic basis of this disease on that 8th day. And we're dealing with something very different after day 8. And my treatment has been such throughout the pandemic. My staff noticed the remarkable recoveries of my patients, both nurses who live in the community and were witness to all the death and morbidity in their respective areas. They were well aware of how critical patients were presenting and recovering within a few days. So they and the patients who I had treated encouraged me to make this information freely available. So I decided to write a paper on it. With my background in science and research, I decided that I'd like to share it with doctors in my area. There's a lot of controversy about outpatient protocols, so I didn't want to publish it. I didn't want to go live with it. I was, I'd say, afraid of having censorship. So I passed it on to all my friends that are doctors. I passed it on to the Minister of Health in South Africa, to CEOs of hospitals, to my principal in the college in India that I studied, and shared it with chat groups on doctors in India. I shared it with a friend in Latin America who was working there. A few patients shared it with friends and family abroad so that they could have a look. I got a great response from abroad. In South Africa, we had a lot of silence. I think there is this general fear of treating coronavirus with protocols that are already seem to be set in stone. A lot of doctors around the world contacted me, and we've had some fruitful discussions over the past year. But it has been difficult to get the general medical community to understand what we were doing. It's only when I got in contact with Dr. Marcus Sanchez-Gonzalez and we found the pathology behind what I was saying that people started to look more closely. The crux of what I do, Jean-Pierre, is the understanding that we're dealing with a biphasic illness. The pathology changes on the 8th day. The treatment should change on that 8th day. A lot of research, a lot of treatment protocols have had a lot of controversy surrounding them. And I'm of the opinion that that kind of controversy seems to be because of there's no recognition that this is a biphasic illness. And if we do not look at it in that light, then our discussions might be a little out of context. And we'd find medications that work in the first phase, the viral phase, don't work in the hypersensitivity phase post day 8. And so you'd have this controversy of people saying it works and some says it doesn't. And I think we need to be very cautious about understanding where in the disease process our outpatient treatment is actually intervening.
Okay. Thank you so much. Thank you so much for these explanations. I have plenty of questions to you, but I'm going to put those on pause because I think we should listen to Dr. Bernstein now, if you don't mind. But thank you so much. Amazing presentation you did, and I think we will continue the conversation on your treatment just in a few minutes.
Sure.
Dr. Bernstein, did you see 4,000 patients already in Canada? As you are the main leader in outpatient treatment in Canada.
No, I haven't seen 4,000 patients. I have my own roster of patients in my family practice. This is certainly a hard act to follow, following Dr. Chetty here with very, very impressive experience. You know, Jean-Pierre, I can only talk about my experience as a family physician, a frontline clinician, practicing in Canada, where there is no generally accepted outpatient care. I'd just like to describe my own experience with my own patients with COVID during the 3 waves that Canada has been experiencing. We're currently in the 3rd and most significant wave. But during the first wave, I only had a few patients who were diagnosed with COVID-19, and it was just in one family, and we knew very, very little back then. And these 3 individuals actually had an uneventful recovery. They didn't require any intervention. One was elderly, 2 were of around their early 60s. And they had mild flu-like illnesses and loss of smell and taste. But fortunately, all of them recovered without any complications. They didn't require hospitalization. Anyways, that was all I saw within my own practice during that first wave. And in the summer of 2020, last year, the case counts in Canada went quite low. And life was sort of returning back to normal. Everything was opening up, and people were trying to have a normal semblance of life again until probably around September, when it seems to be coinciding with the return of school, and the second wave began. And that's when I started seeing more cases, more incidences of infected patients within my own practice. And wasn't a huge number, but maybe a couple a week, and most were young and had, again, uncomplicated illnesses that didn't require any intervention. Now, while all of this was happening, I've certainly been following all of the news, the science regarding outpatient treatment that I had not yet been using within my own practice. So from the very beginning of the pandemic, I've been following some experts online, and specifically Dr. Chris Martenson, who did some fantastic coverage of all aspects of the pandemic, really from day one. And basically, he's a science-based individual, and he'd be covering all of the clinical trials from all of the different products and presenting them on a nightly basis. So I would tune in every single day, learning more and more about the different options that became available off-label, for possibly managing your patients with COVID-19. As time went on, by early November, I had my first significant patient that was brought to me who was not doing well. She was a woman in her 60s who contracted COVID in the workplace, and she was very symptomatic. She had been to the emergency department a couple of times, not sick enough to be admitted, but discharged home. Again, the usual instructions that are given to patients: you go home, you isolate, drink fluids, take Tylenol, and if you get worse, you come back to the hospital. her son, who's a colleague, asked, "Can you help?" He knew, that I had been following, some protocols, and because she was not doing well, it was at that point that I decided to treat my first patient with off-label use of one of the medications that we'll talk about later. In the meantime, I had been recommending to all of my patients all of the common nutraceuticals that had been recommended. So that would include vitamin D, vitamin C, zinc, selenium. Later, I added quercetin to the regimen as more information regarding that came about. So this is something that I had been recommending to all of my patients right from the get-go. Back in March, I had sent out newsletters to my patients saying, this is what I recommend to help support your immune health, so that should you contract this virus, you will have a better chance of fighting off the infection. And I, being a member of another organization called the Canadian Integrative Medicine Association, we had been meeting weekly back in February and March of last year, and we've been discussing all the nutraceuticals. And so in May, we had published a recommendation on the CIMA website. A press release was sent out, and this is what I've continued to recommend to my patients from a immune support perspective. Anyways, with the patient that I did treat off-label, she had a dramatic response within 24 hours. And that's when I thought, there is something to this. That's when I started paying more attention, and I felt, more comfortable using these medications off-label, even though the guidance from the organizations within Canada don't recommend any particular treatment. Again, the instructions are go home, rest, and if you get worse, you come to the hospital. Now, this has been particularly concerning to me, especially in this third wave, where the numbers are up, hospitalizations are up, ICU admissions are up, and I feel very uncomfortable not offering my own patients the opportunity to treat them based on scientific evidence. This is not snake oil. There are clinical trials to support all of these medications that that we are using, and so my support for my patients has continued to date, particularly in this third wave. And those patients who have been treated early really have had quite nice recoveries. There are exceptions that the later you start, you need to work harder. So as Dr. Chetty was saying, after in the second week of illness, we're in this different phase. It's this very inflammatory phase. So the medications that you might need are quite different, and we use combinations of therapies to help our patients have a speedier recovery, and hopefully they won't end up in hospital and in an ICU on a ventilator. I'm quite concerned with the current state of affairs in Canada right now, because the ICUs are full and the experts are talking about rationed care when there aren't enough resources to support the patients in hospital. So I want to do whatever I can to help my patients get that support early so that they don't get to that phase. So that's pretty much my story and the patients that I've been treating within my own practice.
Thank you so much. I think you have much more to say, but I think it may be time to bring back our two other speakers and let especially Dr. McCullough, welcome again. Your reactions, Dr. McCullough, to the two presentations you just heard.
I think what the listeners heard, and certainly what I learned, is that the response to the pandemic is really about innovation. You saw Dr. Chetty's clinic. I mean, a very modest clinic where he's not surrounded with a lot of intellectual support. What he had to do is he had to respond with his clinical intuition, his fund of knowledge, his ability to adapt and think through problems independently. This is really the high ground of what doctors do. And the same thing with Dr. Bernstein. You saw Dr. Bernstein, getting into it. Canada, you could get a sense that he feels a bit worried about the conventional thinking as it would. I was on national TV this week in the United States, and what I told America is I think our public health officials right now are running about 6 to 12 months behind in the application of scientific data and concepts. And it has to do with how public health moves. Public health is very slow because we're used to chronic disease models. Our public health agencies are not designed to respond on a dime to save a country from a viral pandemic. The only thing that can save our countries are heroic doctors like Dr. Bernstein and Dr. Chetty in terms of their ability to have alacrity, the ability to think quickly and understand that this illness is multidimensional. It is not going to be treated with a single drug. I think that's the very first thing. So the next time a public health official makes a proclamation about a drug or a major journal about a single drug, I keep thinking to myself, we never did that with HIV. We never did. We looked for signals of benefit and then acceptable safety, and we started to assemble drugs into combinations. We always do that for viruses. The other thing I think Dr. Chetty and Dr. Bernstein would agree with me is there's been way too much focus on viral replication. So everybody wants to make the biggest sets of inferences on favipiravir or hydroxychloroquine or ivermectin or remdesivir. It keeps going and going. And what I learned from both of them is said, wait a minute, okay, viral replication early, sure, if we can do something there, fine. But this is really a disorder of immune dysregulation. It's a disorder that involves a variety of mediators, cytokines, histamine being one of them, interleukin-6, many others. And then it's also a thrombotic illness. And it's the thrombosis, I think, that's so alarming to all of us. So that's really my reaction. I think it was terrific presentations.
If I may follow up on your amazing comments, this ability of Dr. Chetty to avoid not only hospitalization, but oxygen. Can you comment on that? Because this is huge in the sense, especially when one knows the situation in India today.
Well, it's remarkable. In the last few weeks, I visited an early treatment center in Dallas, Texas, run by Dr. Yvette Lozano. And she had actually set up her entire clinic to treat COVID. And all of her staff got the virus, they recovered from it. And then she basically ran almost like a military clinic. People lined up on the sidewalks for blocks in order to see her. And she did a variety of things. She gave in treatments. She had some patients transiently receive oxygen. She certainly used a multi-drug combination. It's interesting to hear how doctors all over the world are coming up with different combinations based on their observations. And interestingly, you know what she did is she had an arm-leg ergometer, basically an exercise cycle, and she would have hypoxemic patients literally exercise through hypoxemia and was able to get them to rebound. I just got off the phone from Dr. Alan Bain in Chicago, who's also dealing with hypoxemic patients, but able through multi-drug therapy, just like Dr. Chetty observed, do the same thing, avoid the hospitalization. I think the mistake is conventional thinking doctors have thought hypoxemia, have to go to the hospital. There's nothing we can do. But this ability to show courage and use clinical instincts really is paying off.
As you all know, the early outpatient treatment is over a year old. It started very early in the pandemic in France, in New York, in other locations. And today we have a better understanding, we have better knowledge, but research, conventional research still focuses on single drug large trials and does not, basically rejects the complete concept of outpatient treatment in Canada with very strong enforcement, with just a few doctors daring to prescribe off-label on an ambulatory basis. In the US, there is vast repression too. Is there a way out? Is there a way to get the medical authorities to have a fresh look at outpatient treatment, knowing the kind of results? And as you know, Dr. McCullough, who I interviewed here, for example, Dr. Tyson, Dr. Farid, who have also this very long series of patients being treated with extremely few hospitalization, very few, extremely limited mortality, and still their practice of outpatient treatment is being rejected by the medical establishment.
Well, let me just respond to that very quickly. I want the audience to understand what off-label means. The label or the full prescribing information for a drug is what the regulatory agency grants the sponsor of the drug at the time of the application, and it grants advertising rights. So because of the pandemic is brand new, of course, every single drug is going to be off-label because no company has brought forward a single product in order to have advertising rights. So the advertising rights of a label have nothing to do with medical practice. About 40% of the drugs we use in our practice have nothing to do with the advertising label of it. I think that fear of contracting the virus themselves, and also fear of engaging with the pandemic, is driving most of the physician response, that is to do nothing for their patients. But it's really brought an opportunity for heroes like Dr. Bernstein and Dr. Chetty to come forward, and we've organized an entire network of these heroes across the world. We have over 500 heroes on the C19 network, and we are breaking through all over the world. We have in the United States, we have C19, we have the Frontline Critical Care Consortium, Frontline MDS. In Britain, we have the Panda Group, and we have the Heart Group. There's the Treatment Domiciliary Group in Italy. There's a whole variety of groups that are breaking through all over. And in many ways, we need these heroes. Keep in mind, the very first doctor who tried to put a patient with polio on the iron lung machine, which became the critical savior of polio patients, he was thrown off staff and thrown out of his hospital. So history is replete with these examples. What your listeners are looking at right now are the innovators, the people who are going to deliver us out of this pandemic. Keep in mind, patients are getting the virus even after they're vaccinated. So we need early treatment. There's no way to get away from it.
Thank you. Dr. Chetty, you didn't elaborate on your interventions in the viral phase of the disease. Can you explain if you do anything at that stage? And also how you built your confidence of not providing any oxygen to your patients, because that's kind of standard of care in this case when oximetry goes down.
Jean-Pierre, the early phase of the illness, I very quickly recognized as typical respiratory viral infection. Yes, we did have the odd gastrointestinal symptoms, and it seemed to be self-limiting in a majority of patients recovering within 6 or 7 days, showing those signs. So my treatment protocols were purely symptomatic. I did use hydroxychloroquine in the first wave, but my use of hydroxychloroquine and ivermectin was very limited simply because of the controversy and availability in South Africa. But the idea behind using those two medications was not for their virucidal effect. It was more from an immunomodulatory perspective, because I had an understanding that we're dealing with an immune illness. So I started initially hydroxychloroquine pretty early in the first wave. I did find benefits with patients on hydroxychloroquine not having such a severe reaction on the 8th day. But I did find that the viral illness itself didn't require very severe or serious intervention. I managed to treat patients symptomatically. A majority of them recovered. Those that developed co-infection with bacteria required a specific antibiotic. It was simply treating the ordinary viral flu. There was no difference, and you could not tell coronavirus apart from a standard flu. And so the treatment protocols remained the same. Monitoring patients, making sure they showed daily recovery, addressing symptoms as they worsened, if they did. And a majority of patients recovered from that. The other medications that I started in the first 7 days was in anticipation of what might transpire on the 8th day. So I looked at medications like doxycycline that would decrease viral replication through its inhibition of protein synthesis, that would protect other family members from the spread of this virus from an infected person. I looked at montelukast. It's shown to be suppressive of anaphylactoid kind of reactions. It does have some mast cell stabilizing properties. So I looked at starting patients earlier on that. I was well aware of the clotting problems that occurred post the 8th day. So patients were put onto aspirin prophylactically. So a lot of my initial treatment was in anticipation of what was going to transpire, if at all, on that 8th day. I did find some genetic predisposition. In certain families, father and sons were affected, but an aged mother with 2 stents, nothing happened to her. So I noticed that there is this kind of genetic predisposition, and it was feeding into the theory that this is likely to be hypersensitivity. And so I used that information to educate other family members, so that when a father came in with a severe reaction and a week later his son presented with a sore throat, I expected him to have a severe reaction too. So I warned him about the 8th day, and a majority that happened. So my initial treatment is basically treating symptoms and starting medication in anticipation of what might transpire from the 8th day onwards.
Dr. McCullough, do you want to comment on this?
Yeah, I wanted to ask you a question, Dr. Chetty. In your experience, how important is fever indicating viral replication, or the cessation of fever indicating a transition to the next phase?
Dr. McCullough? I've had patients present with sore throats, severe sore throats, lots of smell, but normal temperatures. So I found temperature screening not to be a very good indicator of the illness. But the thing that I found that really made a difference, it was vitally important for me to document the first day of illness. Now, all of us have our varied degrees of normal. When the weather changes, we develop a runny nose, and that's no reason to be panicking about coronavirus. But we all recognize the day when we started to feel unwell. And so I asked patients, when did this start? And the guy would say, on Tuesday. And I asked, on Monday, were you perfectly fine? And he said, yes. So you started to notice you feel unwell on Tuesday. Yes, my body was sore, and I noticed I'm coming down with something. And then when it came to recovery, yes, we had patients with fevers, and on medication, it subsided within a day or two. But nearly all of the patients reported a feeling of recovery by the 6th or 7th day. There were those that recovered very early. But by day 6 or 7, patients reported that they were feeling a lot better. From interviews with the community, Dr. McCullough, it became quite apparent that when people narrated the illness and death of loved ones, it rang true simply because they would tell me, he was looking like he was getting better. And suddenly he took a turn for the worst, and he ended up in hospital and passed away. And with trying to educate patients about the importance of the 8th day, they started to notice that pattern with family members that had passed away. That you're absolutely right. He felt sick on a Tuesday, and the following Tuesday, on the weekend, he looked fine. But suddenly on Tuesday, he took a turn for the worse, and we had to rush him into hospital. So I started interrogating the symptoms around that 8th day, because I needed patients to come in early. Any hypersensitivity reaction requires an early response for us to stop it. And that's where the full ambit of my treatment focused, on educating patients. I had patients where the 8th day fell on a Sunday and my practice is closed. And so I educated them about this 8th day. Those that had the reaction promptly had it on that very day, but had to wait 24 hours to get to my assistance. And in that time, they deteriorated so severely that I had a tough time getting them back. And so I decided that I needed to find a way to preemptively get to these patients. So I printed an emergency script out. For the second wave, I found that the average dose of prednisone was about 80 milligrams a day per patient. Of course, look, I've had patients on 100 milligrams 3 times a day to stop this reaction, but I found the average around 80 milligrams. So I printed a script with prednisone 80 milligrams daily for 5 days and promethazine 3 times a day for 5 days. For those who can afford it, to start montelukast, all patients were started on Ecotrin or aspirin early on. And I put a little leaflet on this to say, do not start this medication before, and in red, I would print their respective 8th day. And below it said, and only if your symptoms worsened. And then I'd give patients the script and I'd ask them to keep the medication handy. And on that particular day, if they noticed either breathlessness, fatigue to the point where you feel like you want to sleep the whole day, or the onset of body aches and pains, but a burning kind of joint pain more especially, like an allergic reaction in the joints, arthritic kind of pain, allergic arthritic kind of pain, that they must combine this medication immediately with what I've started them on and get to me timeously. That bought a lot of time for patients to get to medical attention. But when it comes to oxygen itself, I found that early treatment, no matter, I've had patients with saturations of 40%, who were completely breathless, who were actually getting the crepitations of cardiac failure. And even with those, I found improvement in their saturations within a few days. Some patients in that critical condition were advised to go to the local clinic and have an hour of oxygen every day just to settle them down. But they improved on the medication. I've had a very few cases where I did initially contemplate getting oxygen into my practice, and it can be a bit of a difficult task to do that. And very early on, I found the clinical recoveries that I was having negated the need for that.
Dr. Bernstein, do you also note the importance of noting day 1 of symptoms and then sequencing like Dr. Chetty?
Yeah, absolutely. I'm dealing actually right now with a patient sort of got caught off guard when she contacted me and didn't realize that this, could have been COVID. It was just called the office and had some, minor symptoms. And anyways, we realized it by day 8, she's already in this, the second phase with the breathlessness, and that's when I realized this is COVID. This is not a cold. She had not gone for a PCR test and has not gone, but is clearly COVID, and she does not want to go to hospital. So this is absolutely true. I tell my patients there are these 2 phases, and you might feel fine during that first week, and then all of a sudden, bam, things can go downhill very quickly in the second week. So it's best to target them early to minimize that inflammatory phase. But yeah, you're completely correct, because with this patient right now, I'm having to use multiple agents, and what Dr. Chetty just described. Actually, I'm learning a lot from you right now that I'm underdosing the steroid. 80 milligrams as an average dose is I would say much more than my usual 50 milligrams that I use in patients with asthma who have a severe exacerbation. So I might have to tweak my my protocol a bit to hopefully improve things better with her and my other.
No, I can give both of you some feedback. I had COVID myself, and I have background asthma, and I'm 58. I also have atherosclerotic cardiovascular disease, and I can tell you I got through that first phase, and I was starting to feel better. I was in an FDA-approved treatment protocol, so I received hydroxychloroquine, azithromycin, zinc. I was in another, that was a open label protocol. I was in another protocol where I took either placebo or colchicine. So I was really loading up on the drugs. I was worried. And I did develop pulmonary involvement. So I have a sense of what that shortness of breath feels like. And it's interesting because the feeling is not like asthma. Asthma is like a bronchospastic. I feel like my chest is like, this is different. This almost feels as if our lungs are stiff. There's a stiffness to them. And I was going up and down stairs just trying to see if I could, am I really breathless or not? And I did keep track of the days. And it turns out I ended up starting steroids quite late. I started steroids on illness day 17 because I really tried to ride it out and I just couldn't bear it anymore. The thing I've noticed about steroids is that's actually what makes people feel the best. And it's not just shortness of breath at that stage. There's an overwhelming feeling of fatigue, generally feeling unwell. People think they just can't make it. And I've relied on them over and over again. I've, believe it or not, settled on a little lower dose of prednisone 40. I'm interested that both of you are using prednisone. I've never really had much traction in my own mind on the use of dexamethasone because I thought it was just an odd dose that was chosen in the recovery trial. When we use dexamethasone, it's a glucocorticoid. We usually use 10 milligrams 4 times a day, but 6 a day was the oddest dose. Prednisone is much more balanced glucocorticoid and mineralocorticoid, and we're so familiar with it, and the pharmacies stock it. So there's been a range. In the hospital, I have advised doctors when patients are languishing, just go ahead and use like Solumedrol 60 every 12 hours, use more. But we've fallen into different patterns. Bernstein is at 50, Chetty's at 80, McCullough's at 40. We're at a little different zone. Have either one of you had some experience in using colchicine in addition to the other drugs?
I'm using that right now with that patient. So,
okay.
Yeah, and that would be actually my first experience utilizing colchicine. I'm really trying to do everything to prevent hospitalization, so I figured I'd throw the book at her.
How about you, Dr. Shah? Have you used it at all?
No, I haven't, Dr. McCullough. I haven't had the need to use colchicine. But just to come back to that point on steroids, in the first wave, I found that that dose of 50 milligrams was greatly beneficial. The majority of patients had respiratory symptoms in the viral phase, and 50 milligrams was never needed to be increased. All the patients recovered. I started some on 50 and tapered it down by 5 milligrams a day over a 10-day period. The others needed a longer initial dose to see clinical recovery over a few days before I could decrease. When we had the second wave, 50 milligrams did nothing. And so I looked at this. I was still getting the symptoms on the 8th day. I was still getting a hypersensitivity kind of reaction. The first few patients I treated were very difficult to get back. And so I looked at this and I thought, if I'm dealing with a hypersensitivity pneumonitis, everything needs to be done to turn off that tap. Otherwise, I'm going to have far more mediators to deal with along the way, and that's going to spiral into a cytokine storm with epithelial damage in your lungs and all the rest, that fibrosis that will go with it. So I slowly started adjusting doses. And I found that with some patients, I needed doses as high as 300 milligrams 3 times a day to get them to stop. But the rub is, those patients on that higher dose showed recovery within 2 or 3 days, and I was able to start tapering it off. I subsequently found that a very good marker for the dose of steroid is my interleukin-6 levels and my CRPs. I've had patients present with CRP levels in the 600s, and my entire aim is within 2 or 3 days to have that turned around and returning to baseline. So I put patients, when I realized that the steroid dose needed to be adjusted, I would check my CRP levels, start patients on steroids, and the very next day repeat it. And I wanted to see a downward trend in both. I did find problems with the D-dimers going up and trouble with coagulation, but that seemed to take a little while to set in. Initially, D-dimers were normal while CRPs and interleukins were very raised. So I had to watch those even though I managed to get CRP levels under control. So I found those to be very, besides a lot of my patients cannot afford blood testing. So I had to use clinical improvement as a measure of the efficacy of or dose of the medication I was using. So every patient was schooled to say, I want you to improve by this day. There must be no worsening of your symptom. And I noticed while doing that it seemed to have the same outcomes.
Well, I have to say, I've managed directly somewhere between 100 and 200 patients, and I've advised on many hundreds more across the United States, in some cases the world. And I have to tell you, I think a small fraction I ever had any blood tests on. There's a few patients who had chest X-ray or CT data. And I agree with both of you. I think that the main thing is actually clinical improvement, just using your clinical judgment. If you have good patients and a good doctor or provider can get a real gestalt of how their patient is doing. We published a paper from our hospital, Baylor University Medical Center in Dallas, showing interleukin-6 is clearly related to prolongation of the QT interval. We had a dramatic case of torsades de pointe and death with polymorphic ventricular tachycardia. There's been recent publications supporting this as well. Initially, people wanted to blame the antibiotics or hydroxychloroquine, but it turned out it was the cytokines that were really affecting the heart. And we know now that 50% of patients who are admitted to the hospital have elevations in cardiac troponin. They have a form of myocardial injury. So what we've learned so far is that we need to use drugs in combinations. I've kind of organized them in 2 publications now into kind of a bundle of nutraceuticals, drugs that could be considered anti-infective, something to slow down viral replication if we can catch it early, immunomodulators, which can include prednisone, dexamethasone, inhaled budesonide, and also colchicine. And learning from Dr. Chetty, I think we should add in there montelukast and antihistamine, something else to supercharge that middle bundle. And then the last piece is antithrombotic. And groups from UCLA have shown that thromboxane B2 is markedly upregulated in this illness. And so this is far beyond a baby aspirin a day of 81 milligrams. Yes. I use a full dose aspirin 325, and I have no hesitancy to put patients on low molecular heparin or other antithrombotics. I've been so impressed in patients in the hospital developing thrombosis in their IV lines, their dialysis lines, etc. The fatal cases that I'm aware of, and I've had some in my practice, have all been thromboembolic at the end.
I'd like to...
Dr. McCullough, if I add to that, I've had a lot of patients with clotting issues as well. And I was always of the opinion that one of the mediators that might be released on the 8th day was platelet activating factor. And that would cause the microemboli and, of course, deplete platelets. In South Africa, we had a lot of cases of patients being anticoagulated with low molecular weight heparin and developing hemorrhage because of low platelet counts. And doctors were looking at D-dimer levels and treating. When I looked at that, I used, like yourself, very higher doses of aspirin. I also looked at clopidogrel, that's 75 milligrams a day. It seems to have antiplatelet effect. The one drug that I was looking to consider that I never got to, in ginkgo biloba, there's ginkgoside B, and it's a platelet activating factor receptor antagonist. And my next was to actually look at that. Those patients that showed D-dimer elevation post 8th day, even with being on aspirin or clopidogrel, I would start them on Xarelto, an oral anticoagulant, early on. I've had patients with elevations in D-dimers 10 to 15 times the normal limit. But over a period of 2 or 3 days of starting on these kind of medications, Pradaxa, Xarelto, I found that over 2 or 3 days I had a turnaround, and those patients' D-dimers returned to normal. So I was of the opinion that I should not be looking at anticoagulating patients actively until they clinically presented with symptoms of emboli. Up to that point, the D-dimer level was just a risk factor.
Well, we published a paper with the Italians from the Coracle network that's actually, I think, a pretty useful paper. And what we did is we applied the CHADS score, the CHADS VAS score, which is a general score for atrial fibrillation, cardiac thromboembolism, but it's a general frailty score. And so the CHADS VAS score actually predicted, in a way, mortality that's almost certainly responsive to anticoagulation. So I agree with you. We don't have to anticoagulate everybody. In my practice is kind of following Chad's Vest, patients with heart failure, patients with other medical illnesses superimposed, and it's not everyone. Almost all the nursing home patients, I think, are very high risk, and so those patients we've advised anticoagulation. The listeners may wonder, listen, these are a lot of anecdotal observations here. Has any of this actually ever been published? Well, let me tell you, there are no randomized trials of using 4 to 6 drugs in COVID-19, none, and none are forthcoming. But to the best we can, despite the headwinds, there have been important publications. Dr. Vladimir Zelenko deserves a lot of credit. He fought against all kinds of adversity in his early New York experience, using very early regimens of hydroxychloroquine, azithromycin, zinc, and steroids that he published with Dr. Roland Derwand, that there was approximately an 85% reduction in hospitalization and death compared to expected values. And then here in Dallas, I teamed up with Brian Proctor, who was doing the same thing, again, using different, because we're not able to meet anymore with one another. So we're all inventing our own approaches in our clinics. And Brian Proctor found the same thing, about an 85% reduction in hospitalization and death. It sounds like Dr. Chetty and Dr. Bernstein may be ahead of that because they have a kind of a more careful approach. When I've lost in this approach is because patients present too late. And if I can catch a patient early, I am extremely confident I can deliver them through the illness without hospitalization and death. Dr. Bernstein, would you agree with that?
100%. Clearly, the earlier you start, the faster they will recover. What you see, what's going on in the hospitals, it clearly shows that those who are not getting treated in that first phase are all ending up, or not all ending up, but a significant number, more than the healthcare system can handle, are ending up in hospital.
You brought up an important point. My observation is almost all of the hospitalizations and deaths occur in untreated patients. They get no outpatient treatment whatsoever. And there's an important paper published by IP et al. From New Jersey that demonstrated that if even patients who are hospitalized, if they get some outpatient treatment, even if it's late, they have a markedly reduced mortality when they come in the hospital. So I think it's very important to get this message across that, early ambulatory treatment, not only does it reduce hospitalization and death, in my opinion, it actually reduces viral spread because we reduce the period of time of viral shedding. We reduce the patients panicking and contacting others during this treatment period. But even if they get hospitalized, they have an easier course than those who get no treatment whatsoever. And that's the majority. We've had millions of hospitalizations in the United States, and it's a tragedy, and the families are desperate for treatment. And because treatment isn't offered, the poor patients, especially the seniors, they suffer at home until they can't breathe anymore and they go to the hospital. So we have to break through with early treatment.
If I may jump in right now and maybe ask you, the three of you, to comment on the question of testing, because one of the key factors in delayed treatment is delayed testing or reliance on testing for a diagnosis. So maybe Dr. Chetty first, how were you doing to diagnose your patients? You mentioned that many of them cannot afford a blood test, or could they afford a COVID test? And is the COVID test any useful in this context?
Jean-Pierre, I initially there was a drive in the first wave towards testing. So a lot of patients got tested freely by government in the first wave, but I had a healthy suspicion that the test wasn't as reliable as it should be. I knew about its design flaws, and of course I had the concerns about the way the test is actually done, the competence of the tester itself. So I did not rely on the test results solely from the start. I was looking at this from a clinical perspective. Very early on, it became obvious that the tests were giving me a lot of false negatives. In the second wave, a lot of patients couldn't afford to keep doing these tests. So my method to diagnosing COVID was to educate every patient that came in with flu-like symptoms that there was a possibility that this would be coronavirus and that they should isolate from society for the next so many days. Plotted the 8th day and explained to them that that would be the day you would report back those symptoms. I only considered testing patients that came back on the 8th day because I had a healthy suspicion that this would be coronavirus. Now, those patients who recovered by the 7th day and showed no worsening on the 8th day, by the 10th day, they were allowed to integrate back into society, and it made no difference to me whether they were positive or not. They would form part of this pool of herd immunity we're trying to build. I didn't see the point of testing asymptomatic patients and isolating patients and that kind of thing. I think it created a lot of unnecessary panic. Because if you're using a test that's not sensitive and not reliable, what are we trying to achieve by that? It would skew research, it would skew opinion, it would allow for manipulation of results. There's a lot that would come into play. So I decided from very early on that this was going to be a clinical diagnosis on my part, and the test would be used to satisfy the government officials that needed to know the positives in my community. But there were a lot of positives I didn't bother testing. They recovered by this. There were families of patients. I mean, 2 had coronavirus. Why do I test the other 4? Everyone developed symptoms within the same time. And those that recovered by the 7th day, well, by the 10th day, they were allowed to go back into society. The others that developed symptoms on the 8th day got tested, and it was confirmed it was corona, but they got treated. Whether the test came out positive or negative was absolutely irrelevant in me reacting to clinical symptoms on that 8th day. There was no way that I was going to defer treatment on a negative test.
Dr. Bernstein, you're treating somebody right now who doesn't have COVID testing, right?
That is correct. I would prefer that she did have a test, but I am going on the assumption, she has a daughter that's sick. She had an uncle that just passed away a week ago. When it looks like COVID, it smells like COVID, chances are it's COVID, at least in the context of what we're seeing right now. There has been no influenza this year. I have not seen in Canada or in my own practice or anywhere a single case of influenza this year at all. I don't even think they're testing for influenza anymore because there hasn't been any influenza. Whereas in typical, winters and early spring, there'd be tons of influenza, but for whatever reason, we're not seeing that. But, generally when patients are presenting with the typical symptoms of coronavirus, which is quite different from influenza and quite often quite different from the common cold. In the common cold, you don't see that loss of sense of smell and taste. It seems very, very specific, to coronavirus. We don't see that in influenza. So, and plus the cough is different. When someone presents in influenza, which I used to see in my office all the time, they would come in, it starts off high fever and they've got that horrendous hacking cough from day one. Whereas in COVID, the cough tends to be quite different. It's often a very dry cough. So, and plus there's all these other features. You have gastrointestinal features. It's just there's a whole constellation of symptoms that we see in coronavirus that are pretty unique, that are not seen in many of these other respiratory illnesses. Coronavirus is not a exclusively respiratory illness like pretty much influenza is.
Right. So, I wanted to support both of you. There's an important paper published in I believe Nature, where it looked at patients who looked like they had COVID. They had all the clinical features of COVID. They had depressed lymphocyte counts, high D dimers, high C-reactive proteins, the characteristic chest X-rays and CTs, but the tests were negative. And they just kept going deeper and deeper. They went to nasotracheal aspirates and then bronchoscopy, and sure enough, they found the virus. So what I learned from that is that I agree with you. The clinical syndrome is very distinct. The test has problems with respect to sensitivity, particularly if there's not much nasal secretions. And then the tests in the asymptomatic phase, it's rare when they're positive, but when they are positive, they tend to be false positive. So the tests have never been approved or scientifically shown to be of any value for asymptomatic testing. So if I was to encourage the listeners, let's stop asymptomatic testing in schools and athletes and airplanes and everything else. It's never been, the regulatory agencies have never approved the test for that use, and there's no scientific value. I get the tests when they're available and they're helpful, whether it be the antigen test against the nucleocapsid or whether it be the PCR test looking for that fragment of a viral RNA. But I've treated plenty of patients based on the clinical syndrome, particularly patients who honestly, they're older, they're senior, they don't want to leave their house. It just actually getting the test creates a hazard to others. We can actually get early treatment sent at home. So I want to encourage the listeners to listen to Dr. Bernstein, Dr. Chetty. Senior clinicians can diagnose this illness without the reliance of COVID testing. The COVID testing became something that the community health organizations and the governments are interested in terms of a case count. But to us as doctors, we don't do a test to diagnose acute asthma exacerbation. We treat it, and this falls in that same category.
I had an interesting case there. I had a patient present to me with flu-like symptoms, and by my protocols, I said, look, isolate yourself for so many days and the rest. He was pretty concerned about this being coronavirus, and I advised him that a test is meaningless to me. It's a waste of his money at the time. He subsequently, in that first 7 days, went and did 2 coronavirus tests on separate days. Both had come out negative. So he was convinced that that was a negative test. He presented back to me on the 8th day with the symptoms typical of corona. So I promptly started him on steroids and the antihistamines, montelukast, and he started to recover, but a little slowly. And so I was contemplating by the 2nd day to increase his steroids. So I decided I needed some confirmation that I'm dealing with corona. So I sent him for a test. That came out negative again. So I sent him for a lung x-ray, a chest x-ray, and it showed a little bit of clouding, but not typically coronavirus. So I looked at this and I thought, am I missing something? And is this just a bronchitis that is getting worse? And would the steroid hamper his recovery? Because I hadn't at that point had him on an antibiotic. I didn't see the requirement for such. So I took him off the steroid for a day or 2, and he promptly worsened. So I brought him back in and I thought, no. I put him back on the steroid, but I did his CRP values, his interleukin-6. I had convinced him that we need some testing done. His CRPs were drastically raised. His interleukin levels were drastically raised. That told me I'm treating coronavirus here. So I, on the blood sample, ran a COVID antibody test, and that came out positive. Now I was sitting with a patient with a positive antibody test, critically ill. That should not happen. If you've developed antibodies, the virus is gone. So I looked at this and I thought, well, he had a viral illness in the first 7 days. He promptly developed antibodies to those. But the viral illness played no part in him reacting to the virus and having hypersensitivity. I'm of the opinion that it's the spike protein of this virus that we seem to have an allergic reaction to. The reason I say that is in our South African second variant, I noticed early on in patients that were presenting with gastrointestinal symptoms. I noticed the higher contagiousness of the variant, and I also noticed these more severe hypersensitivity from this variant. But the mutation of the virus only caused a change in the spike protein. The spike protein had grown by, I think, 40 amino acid base pairs. Nothing else in the virus had changed. And so I looked at it and thought, well, if it's the spike protein that has changed, that will make it more contagious. It's easier to attach to ACE receptors. It had an affinity for those ACE receptors in the gut, so I was seeing more gastrointestinal symptoms. And because of that change in the protein, it was far more allergenic. And so I was seeing far greater hypersensitivity or far more severe hypersensitivity reactions in patients. So the rub being that PCR testing can confuse your clinical judgment. And so we've got to be very cautious about doing a PCR test and using that as the basis for treating patients. I think it creates a lot of unnecessary panic amongst people.
It does. I wanted to pick up on GI symptoms for a minute and just let the listeners know that Kevin Lowe published a wonderful meta-analysis demonstrating that those who do develop GI symptoms do have a worsened prognosis. And in the lab of Sabine Hazen, she actually does full sequencing of the virus in the GI tract. It's very hard to actually get the entire intact virus out of the nasopharyngeal specimens because we have proteolytic enzymes and others that break down the virus, but you can get the virus in the GI tract. And the Chinese have been using anal swabs for a while, which I think is interesting. And what Hazen has shown through the United States pandemic, we've always had about 6 to 8 variants or strains going. The original one was the Wuhan wild type spike protein, but in most recent analysis from the CDC just a few weeks ago, we have 14 variants in the United States. The Wuhan wild type spike protein is long gone. That is gone now. And so the most common variant in the United States is the UK variant. And so some epidemiologists interestingly think that all this distancing and isolation and quarantining has, in a sense, given an evolutionary pressure for the virus to become more contagious because it's kind of hopping from people who are distancing farther away. It's an interesting hypothesis.
If I may bring a question from the audience, and this one is about the applicability of Dr. Chetty's approach to treat COVID to India.
Yes, I've been in talks with colleagues in India. We've been talking about this pandemic from the very start. I studied in India, so I have a large group of friends there, and so they're well aware of what I've been doing with my treatment protocols as such. Now, the current situation in India is a very unique situation. The new variant of the virus seems to be having very mild symptoms in the first 7 days. So a lot of people are having very mild symptoms that are going unnoticed and are presenting to hospital post day 8 with severe reactions, with the breathlessness and the need for oxygen and all the other complications that we see. There also is a concern that the mass vaccination campaign might be masking the initial viral symptoms. So we're not actually finding those patients early on because they got the virus harbored in there, but they don't have severe illness at all. It's only on the 8th day that they develop this hypersensitivity reaction, which causes them to rush off to hospital. So from my perspective, I think we need a shift in the way we manage these patients that are presenting. If we go down the road of trying to kill a virus with the patient on the 8th day, all we're doing is losing time. And if we timeously catch these patients, we might negate the need for oxygen and hospitalizations and buy some time to treat or to select out those that are more critically ill, because a lot of patients would recover on the simple steroids and antihistamines and Montelukast. Those that progressively get worse will need further intervention, an adjustment of dose of steroids, maybe a quick addition of ivermectin to treat the pulmonary eosinophilia, those kind of things. But we'd actually, by treating patients early, sort a lot of the more critical cases out, and we could deal with that, and it would take away a lot of the impact the current crisis is having on the tertiary services that are required. We will negate the need for oxygen in a lot of patients. I'm having a discussion tomorrow with Dr. McMillan, where I'm looking at a few frontline workers in India and how we're going to address this. Because it's of no consequence we sit and speak. We need the influencers and the business community and the medical community involved to change approach. We might be sitting with a country that was stung with the bee, and those that are hypersensitive are presenting to hospital. And that's the approach we need to adopt to start to save lives. That would make a difference, but it's to get the right people that can change policy, have doctors on the ground that would be willing to try these things. I mean, a day of treatment and you'd see the benefit. So this is not rocket science. It's far less invasive than a lot of other treatments that are proposed. And it could change the face of the pandemic. The medications are cheap. They are freely available. They haven't been banned by the World Health Organization just yet. So why can't we do this? But I think it's just the organizational skills that are required to put this response together.
I have here a question, maybe Dr. Bernstein, about the kind of over-the-counter drugs and supplements one can use during the first 7 days.
Sure. Well, we're recommending adequate levels of vitamin D. But what I'd like to say is it's best to have the supplements on board before you get sick, because the ability for your immune system to respond to the immunomodulatory effects of vitamin D, this is a process that doesn't happen the day you take vitamin D. So if your body is full of vitamin D in advance of contracting the virus, that will give you a much better chance of avoiding the ICU. So in any event, some of the protocols are suggesting that individuals take 4,000 units of vitamin D if they're ill. Vitamin C, 1,000 milligrams twice a day. I will say that none of these are based on randomized controlled trials. We don't have that. Although there is a lot of evidence specifically for vitamin D, but for all of the nutraceuticals together, this is basically based on nutrition and the science of nutrition for supporting your immune and cellular health. Zinc, it's recommended that 50 to 100 milligrams. I've been recommending in advance to take 20 milligrams as a baseline, for patients for prevention for optimal immune support. Quercetin, 500 milligrams a day has been recommended. I recommend selenium, magnesium. I mean, there's a whole host of nutrients that you can take to support your immune system. But what I often will recommend for members of the audience to consult the FLCCC, Frontline COVID-19 Critical Care Alliance. Take a look at their eye mask protocol. It has all of the nutraceuticals listed there, plus some of the early outpatient treatment protocols that we're using for both prevention and early outpatient treatment. And it has actually just been updated this week based on emerging evidence and with combination therapy, and because of the perhaps more aggressiveness of the variants requiring a more tailored approach, that perhaps in the first wave, single therapies may have worked better, but now we need a more tailored approach. But I would say consult their site for the nutraceutical recommendations, because it's sound, it's reasonable, and it makes good sense, in my opinion.
Can I get a question in for Dr. Chetty along the lines of vitamin D in the United States?
Dr. McCullough, if you don't mind, if you can just take this question, because I think it's important to, I have quite a few questions from the audience here about, do we need two types of protocols here?
Well, let me just, let's finish the thought, Dr. Chetty, in the United States, we have double the mortality in African Americans compared to Caucasians, double, and striking differences in vitamin D concentrations. Do you still see that in South Africa, difference between black South Africans and white South Africans?
We're in a very unique predicament, Dr. McCullough. Apartheid has separated our communities, so we have a very different dynamic to this pandemic. In the first wave, when lockdowns were instituted, everyone followed it. But our predominantly black community don't have the capability to do that. They live in informal settlements, and so the virus spread rampantly through that community. So we saw a lot of patients initially being of that race group. The others were very few and far between, because they were able to isolate and they were on the supplements. They could afford all those kinds of medications. But in the first wave, we had a variant that presented with the respiratory symptoms. So the black community, as much as we had those severe cases, we managed to get them back very easily. The second wave was predominantly an Indian community. I think when they relaxed regulations, the Indian community went out. They thought, well, the wave is over, and so people spread. So in the second wave, I saw predominantly Indian patients. Yes, there was a spattering of white community and black community. So I started to look at that to see whether there's some genetic preponderance here. But our South African blood services, look, with the data coming out, we've got to be cautious about how we look at this data. The absolute numbers cannot be trusted. So the patterns are more important. And so I looked at the services because they tested every patient that had no sign of COVID when they drew a blood sample to check for antibodies. And they found a 64% antibody level in the black community without exposure to COVID. I think it was about 45% in the Indian community and about 22% in the white community. So I think it has to do with exposure. I was looking at it more from a prevalence of the virus in our society. 64% of a community that has coronavirus makes me wonder about isolation and lockdowns and all that kind of thing, because these people didn't know they had coronavirus and they were in contact with
it.
And
it feeds into the issue of susceptibility. And there are studies showing large proportions of the population are not susceptible. It means, honestly, they've either had cross-reacting coronavirus antibodies or they've had a very low burden exposure. I want to address the issue of multiple protocols. I think what the listeners are hearing is just the natural evolution of things. I can tell you for every single complicated cancer and every single early on in the treatment of acute HIV, there were multiple protocols. So the answer is we would naturally expect multiple protocols, multiple experiences. There's not a single way to treat this illness. It is a dynamic illness, and doctors working using their judgment and the available evidence will arrive at different multi-drug combinations. The principles are there are multi-drug combinations. There's a repletion of nutraceutical deficiencies that's helpful. And in organizing towards the virus early on, immune dysregulation and thrombosis, I think this is very natural. And I'm so grateful to Dr. Chetty and Dr. Bernstein to actually kind of support us in what we're doing.
Thank you. Here's a question for Dr. Bernstein. So what is the question, what is the issue of supply of the required drugs in Canada?
I have to admit, it's a huge problem. So in Canada, there is only one supplier of ivermectin, for example, which is made by Merck, and it is currently on long-term back order. So most pharmacies in Canada have either no supply and can't get it, or very limited supply and with not enough product available. So there are currently no other generic manufacturers of ivermectin. Ivermectin specifically has been off patent for a number of years, but in Canada there are no producers, and right now Health Canada has not authorized any company to manufacture, produce ivermectin. So what we've been able to do is, with the use of some compounding pharmacies who are able, who may be able to provide compounded ivermectin. But what I'm also finding, and this just occurred today, is one of my reliable pharmacies is now out of compounded ivermectin and apparently won't have any product for 2 weeks. So it's becoming difficult in that, you know, while the prescriptions are going up, the demand for some of these off-label medications is increasing, the availability is diminishing. So we have a supply problem if it's specific to ivermectin. For some of the other off-label, you know, therapeutics, it's less of a problem. Colchicine is pretty much readily available at the present time. Fluvoxamine is currently readily available, or you can use, if you're going to switch to another SSRI, such as fluoxetine, that's even more readily available. But right now, the big crunch, supply crunch, would be with ivermectin. So this is a problem. There are pharmaceutical companies that are trying to get authorization from Health Canada to be able to supply and manufacture ivermectin. This has not happened yet. The regulatory process is very slow and difficult, and I'm not sure how to engage the regulators more to make this happen, because we need more of this product for physicians to start using it more. It's no good having protocols where physicians want to use these products and not have the ability to prescribe it.
Let me ask Dr. Chetty a question real quick. Dr. Chetty, have you managed large numbers of patients without ivermectin or hydroxychloroquine?
Dr. McCullough, in all the 4,000 odd patients I've seen, I think I've used hydroxychloroquine in about 100 of them, and ivermectin in about 100 of them. Just to fill in a point, ivermectin, when I looked at ivermectin as a treatment, I never looked at it to kill a virus. I was looking at it, you see, it's used in the treatment of filaria. And the dead parasites trigger a pulmonary hypersensitivity, which causes eosinophilia in your lung, eosinophilic lung. And ivermectin was a drug that could clear eosinophils from your lung. And that was the perspective of me using them. So I limited my use of ivermectin to patients who presented after the 8th day with symptoms of dyspnea, and I found very quick benefit to that. So when it comes to the early treatment, when it comes to prophylaxis, I don't have any data to prove that, but I can truly say that ivermectin is of great benefit when we develop lung inflammation and likely pulmonary eosinophilia. There's a plant in South Africa called Artemisia, which has shown a lot of benefit, but the traditional healers have been pushing government to allow them to treat coronavirus with it. Now, Artemisia is also a plant that's used in the treatment of filaria, and I have a suspicion that it has an effect on pulmonary eosinophilia and the ability to clear it. I've been talking to a few friends in Kenya as well. There's a drug called diethyl carbamazine citrate. It's a first-line treatment for filaria. And the reason it is chosen as a first-line treatment is because of its good effect in clearing eosinophils from the lung, far more quickly than ivermectin can. So I think we might need to look at a broader base of research to figure out the toolbox for that particular thing. So I think governments and things, we need a bit of diversity there.
I wanted the listeners to hear this, because in the United States and in Europe and Canada, there's been a hyper focus on hydroxychloroquine and ivermectin. And I wanted them to hear that this syndrome can clearly be managed without either one of them, and the importance of managing the immune dysregulation and the thrombosis really can carry patients all the way through. I've had the same experience. I've always felt like, gosh, I should use one of the antivirals, but I've had some patients too late. There's no fever anymore. There's no nasal congestion. It's just we're in that kind of pulmonary phase, and I've managed them through. Jean-Pierre, do you have another question for us?
Yes, Dr. Chetty, here's a question. What about the presentation and variations in presentations with variants?
With the variants, what I noticed was that the presentation of the viral illness changed. Like in the second wave, we had a lot more gastroenteritis. Some of the gastroenteritis had an accompanying sore throat, but a majority of patients had gastrointestinal symptoms. So the presentation with the variants, I would expect them to change dependent on their affinity for certain receptors. But the two systems affected here are your respiratory tract and your gastrointestinal tract. And I haven't seen symptoms really outside that. I've seen a few patients with otitises and conjunctivitis, but they are few and far between. So I wouldn't consider those typical initial presentations. I also found differences in the hypersensitivity, the severity of the reaction that presented on the 8th day. And that would be typical of a spike protein, which is changed in the variant. But the course of the illness and the timing around the world has not changed. We're always getting a switch on the 8th day. Be it the Indian variant, be it the Brazilian variant, I've spoken to friends around the world, they see the same pattern. So the severity and the symptoms of the viral illness might change according to the variants. The severity of the hypersensitivity reaction might change according to the variant. But the progression of this illness seems to remain the same. From day 1 to 7 is viral. From day 8 onwards, it's an immune response and likely hypersensitivity to something. And in all, if we do not act timeously, we end with the same multi-system disorders. And I'm of the opinion that all those multi-system disorders, the inflammation, is simply because we haven't turned off the tap early enough.
Here is a question about enoxaparin. Who wants to volunteer?
Well, I can tell you, I have early on, we've used enoxaparin, and there's several inpatient analyses that support it. But to my knowledge, there's no outpatient studies with enoxaparin at this point in time. And ever since we had the data about thromboxane market upregulation, I've had a greater reliance on aspirin, which is obviously easier to get. It's just aspirin at a higher dose. How about Dr. Bernstein? Have you used low microwave heparin in Canada?
No, not at this time. I've been using ASA 325 milligrams, unless contraindicated.
Okay. How about you, Dr. Chetty?
No, I haven't had any experience with it, Dr. McCullough. I tend to stick with the oral anticoagulants that are easier to administer at home, and they have less side effect of bleeds. So they are a lot safer. In those patients with raised D-dimers, prophylactically, aspirin seemed to do the trick, a raised dose. In those patients where I was concerned about clotting, who had a propensity to clot, I would add clopidogrel early on, and that seemed to keep things in order.
Okay.
Here's a question from a medical doctor from Canada, from the West Coast. Any comments?
Well, I'll make a comment on that. That in the FDA application of at least one of the messenger RNA vaccine products, after the first injection, there was a flurry of suspected cases of COVID, in fact, confirmed cases of COVID. And now there have been supportive papers from Israel on this. So we may actually be seeing, if there's 2 injections, we may be seeing an increased susceptibility after the first injection. And it's been conjectured that maybe the early immune response, because keep in mind, the vaccination is against the Wuhan spike protein only. It's a very narrow immunity that's given with the vaccine, that there's an immature library of antibodies that may be facilitating a mild form of antibody-dependent enhancement. After the second injection, it appears as if there is vaccine-conferred immunity. So the cautionary word is for those who are volunteering for the vaccination program to be cautious after the first vaccination. We have seen this flurry, and I've seen it in my practice for sure.
And here is a related, here is a related question.
I've had these in my practice. Currently, I've gotten all my COVID patients over the illness, but 2 weeks ago, 60% of my COVID patients had been previously fully vaccinated. And the US CDC has reported over 7,000 cases, and that's only through our community health reporting system. So only if a community health office called somebody with a positive test, and then we're able to get them on the phone and take down the information, could we ascertain a breakthrough case. So I think the 7,000 breakthrough cases reported to the CDC, in reality, it could be 10-fold that, maybe 20-fold that. It's grossly underreported. The current hospitalization rate reported from the CDC data in the US is 7%. It looks about the same as the COVID-19 illness. My clinical experience tells me it's a little bit milder and a little bit easier to treat. I hope it is. But otherwise, my view is we treat it the same way.
I've recently treated one patient, an elderly woman who contracted COVID about a month after her first vaccination. And I am hearing more and more cases of this. One of the problems with the vaccine rollout here in Canada is because of the limited supply, there's a long interval now between first and second dose. Instead of following the protocol from the manufacturer's product monograph of either 3 or 4 weeks between the first and second shot, they're now being extended by 4 months. So, clearly people are not getting a complete protection. I'm really not sure how much protection you're getting after that first shot, but we are seeing patients who are having these breakthrough infections, including hospitalizations. I just learned of one yesterday.
Dr. Chetty, do you have vaccination in South Africa?
Dr. McCullough, we have had a few vaccinations. South Africa is a bit slow in getting through the vaccinations. But just to add to what you were saying, the vaccinations don't seem to be conferring sufficient immunity to prevent us getting infected. There's been talk about this vaccine decreasing the severity of illness. Now, when I look at that, the vaccine introduces the spike protein to us. And from what I've seen, we are allergic to the spike protein. So a lot of the symptoms that we see as side effects of vaccines seem to be very similar to the symptoms that patients present with on the 8th day. Excuse me. So I'm wondering whether the vaccine is stimulating an allergic response. Because if you look at it, the side effects of the vaccine seem to have body aches and pains and fever and all the different things that we see on the 8th day. And then if you look at the long-term complications, we're seeing patients with thrombotic events. We're seeing patients with myocarditis. We've seen that in patients that were not treated for coronavirus. So are we having the same kind of mild hypersensitivity reaction to the vaccine that is not actually conferring immunity? Rather, it is conferring tolerance to an allergen. And so when that patient eventually gets coronavirus, they were exposed to that peanut before, and their body might not react in such a severe way. So I think these kind of things need to be looked at very closely, because the vaccine was initially meant to stop us from getting this infection. Now the goalposts have moved, and it's only to prevent severe illness. And then, as well, I got to be very cautious about how I look at the results coming out of vaccinations. If I had to look at mortality and morbidity, I would say it's caused by a hypersensitivity reaction. And if I globally look at this, I would say the people that are more prone to having allergic reactions would be the population more prone to having severe COVID illness. And because it's hypersensitivity or immune related. Now, when you go to get your vaccine shot, if you're allergic to anything, you're not allowed to take the vaccine. Now that skews the cohort in favor of vaccine efficiency. And so we're claiming to stop people getting severely ill, but by my analysis, we are vaccinating people that are not at risk of getting severely ill because they don't have any severe allergic history. So I think we need to look at this very pragmatically and figure out what we're trying to achieve with every intervention, be it vaccines, be it treatment, be it prophylaxis. And we've got to set definite goals. We can't have goalposts moving around all the time.
Well, you made an important point that all officials in all countries indicate that patients who have vaccine reactions should not receive the COVID-19 vaccine. And it has come up multiple times if patients have a severe reaction on the first injection, should they get the second one? And in the clinical trials, they screened out patients with any history of vaccine reactions. And in lo and behold, to support you, Dr. Chetty, the rates of COVID, the attack rates in the clinical trials of the vaccine clinical trials was less than 1% in vaccine group and placebo group, less than 1%. So we've been operating on a less than 1% attack rate proposition from the beginning. We certainly have a lot more to learn. There's no doubt about it. We need an early treatment platform in all regions of the world. Jean-Pierre, do you have another question for us?
I have certainly questions and two important ones. I'd like actually to complete on this, and these are a bit my questions, but they reflect many comments received and also I think the priorities of the day. The first one is the presentation of younger people in the ICUs, in hospitals. So how do you today proceed with some form of risk stratification? Who do you treat? Do you treat a teen? Do you treat a young adult? You treat from age 40? How do you proceed with this? And then we'll get to the next point and last point I would like to discuss collectively.
Maybe Dr. Bernstein can take that in Canada. Is it your view that all Canadians who get this illness should receive medical treatment, or do you risk stratify?
I still risk stratify based on their age, underlying comorbid risk factors, and if they're very young, healthy, with no risk factors, and they, if they present, they've gone for a PCR test and they got a little sniffle, they don't necessarily have to be treated. On the other hand, if there are members of their whole household that may be at risk, where the virus is spreading through the house, I might suggest treating the whole family. That way you can get them all in one, get them all recovered early. But I don't treat everyone. So I think you look at age. Certainly, the older you are, I'm much more inclined to treat. Do I treat teenagers? No, I haven't treated any teenagers yet, but I have treated people in their 30s, 40s and up. But I look at the clinical situation, how they're presenting. But my threshold for treating now in this third wave, where things are quite bad in Canada, my threshold is very low. That I'm likely to say, even if they're not bad, I still can't tell if they're going to get bad on the 8th day. So they may be perfectly healthy and still get a bad presentation later on. So I will still entertain the possibility and say, ask the patient, are you interested in receiving early outpatient treatment with a medication off-label, with informed consent, balancing the risks and benefits, although I'd have to say the risks are very low, if not existent. But so it's a customized, tailored approach for each patient.
Okay, Dr. Chetty, how about you? Do you risk stratify or do you treat everyone?
I think my risk stratification is a little different. In the first wave, we saw. Look, my perspective leads me to look at this in a different perspective. In the first wave, we saw a lot of people over 55 getting this illness. Now, I've had patients over 55 that were absolutely healthy and ended up critically ill. And I've had patients who had 2 stents and diabetes and high blood pressure and the rest of the comorbidities, and they had very mild illness. So I didn't look at the risk stratification as the rest of the world did. I looked at this, that in the first wave, people over 55 were probably exposed to an allergen similar to coronavirus, and those that were allergic had developed the relevant antibodies to have a hypersensitivity reaction. The younger population were naive, and so with this first exposure would not react at all. And so they would have viral illness and it would pass off. But it was my expectation that in the second wave, because these patients were sensitized, we'd see a far younger population showing up with hypersensitivity or mortality and morbidity. And that's exactly what we saw in South Africa. In the second wave, I found a large proportion of the population, a younger population affected. It was more the age group from 25 to 45 or 50 that were affected in the second wave. Now, my take on that is that this is a proportion of your population that were previously unsensitized and got sensitized in the first wave. And in the second wave, on re-exposure to the allergen, presented with hypersensitivity. Because I've had a 9-year-old patient, the youngest patient I've had, who had a very severe reaction on the 8th day. Now, he's one of the few kids that I've had, but I've had 25-year-olds present very severely ill, and if they were not attended to immediately, would have ended up in critical care in hospital. So I think my protocol, my way of looking at this is whoever presents with symptoms on the 8th day, that needs to be addressed. As well, mild symptoms untreated showed as long COVID. So I think long COVID is mild hypersensitivity going untreated, and it would result in all these sequelae that we see. Because in the patients that I've treated, I haven't had one come back with a complication. And I haven't had a case of long COVID yet. Every patient that came into me on the 8th day with symptoms got treated and the reaction stopped right there. So I haven't had patients coming back with fatigue and all the things I've been hearing about around the world. So I think the timely intervention is important.
Right. So to support you, the data suggests long untreated periods, severe symptoms, and hospitalization predict long COVID. Conversely, we're starting to build an experience that patients treated properly and early, we can avoid long COVID. I'll just say risk stratification, we've done this in two of our guidance publications, is based on age, and we just picked a line, mortality and hospitalizations rise above 1% over age 50. So we have an older population here in Canada, US. So age over 50, plus we add on these comorbidities, or in younger patients who present with severe symptoms or develop severe symptoms, same thing. So the youngest one I've advised on is an 18-year-old, and she developed really severe symptoms. And we honestly didn't think she needed to be treated. And we got too far behind. She was hospitalized. She nearly went on the ventilator, got late treatment, has a terrible case of long COVID now. It's awful. And I should have retrospectively advised early treatment because she was presenting with severe symptoms. But I've had family members, multiple family members who are young, they get COVID. It's like a mild cold, head cold to them. They get through it and they're in good shape. Jean-Pierre, another question for us?
Yes, and I will ask you to really reflect on this, but I would like to ask each of you your advice to the government of India, to the medical doctors in India, not the hospital doctors, but the doctors, the general practitioners. I would ask you to really put forward your recommendations on how to deal with the crisis that is currently taking place in India. Dr. Chetty, you are first.
Jean-Pierre, from what I've been saying, I think that a lot of patients presenting in India in the hypersensitivity phase of this reaction, and I think prompt treatment is vitally important. It would negate the need for oxygen, hospitalizations, take off all this pressure on the healthcare system. So I would actually suggest that doctors set up a system where they could examine patients, but start immediately on simple treatment that could stop the reaction from progressing. I found that a healthy dose of steroid, antihistamine to treat the symptom, I've seen clinical recoveries in a few hours. And this is the type of intervention we need, simple, yet addressing the cause that would curtail a lot of the stress put on the hospital system. We got to understand that past the 8th day, trying to kill a virus is not going to solve the problem. It's going to waste time, and every day lost will create a lot of problems in the way we deal with this. We got to be quick to it, we got to be simple to it, and we got to be effective in treating it. And I think that's what needs to get put out. A simple dose of 80 or find out the dose, 80 milligrams of prednisone with a simple antihistamine. Treat the symptom as you see it. If it does not save that patient's life, it will at least buy you time to address the complications.
Dr. McCullough?
Briefly, I've looked at the most recent updated Indian guidelines, and I completely agree with Dr. Chetty. They have a symptom-based risk stratification, and they're really starting treatment too late based on symptomatology. So I think they're going to have to go early, simple, and make it effective. Dr. Bernstein?
Well, yeah, I'd like to speak for the Canadian experience that, we have a fairly robust primary care network in Canada. Every patient is supposed to have a family physician. And so family physicians need to be educated. They need to open their eyes and basically be open-minded to the concept of early outpatient treatment and be accepting of the science that is evolving, that, things are not exact. What may be correct today, next month may be a little different, but we sign the Hippocratic Oath. You don't want to do any harm. And in my opinion, doing nothing leads to harm, which is why I am here to help my patients recover. And I would just encourage other family physicians to look at the science, ignore the noise, but help their patients. I see treating COVID-19 as a primary care illness that should be treated by family doctors and not ending up tertiary care in the hospital when they're too sick.
I think this is going to be the final comment. Gentlemen, thank you so much for your participation. I'd like to thank all the audience for your pointed questions and for being here. Again, thank you so much, gentlemen.
Thank you. Great,
Thank you.
great webinar.
Thank you.